I've been working in the NHS for a couple of years now. I started I was recruited into University Hospitals Bristol, which is one of the major acute trusts in Bristol, so a big hospital provider. We're in the middle of Bristol. We run 9 different hospitals, the Bristol Royal Infirmary, plus a whole range of specialist hospitals. And as part of the work in terms of strategy development for UH Bristol, I've been really trying to focus on where UH Bristol fits into this thing which we refer to as the local health economy and the sort of city more generally, and how you crack the particularly difficult nut, which is finding ways to address big challenging issues and things like the health system, which really have no single organisational answer or response. They're all about how organisations work together and how, in inverted commas, the system functions. And a couple of months ago, I stepped into a new role, which is as the Director of Bristol Health Partners, which is a vehicle for collaboration between NHS trusts, so us and North Bristol Trust, but also the Avon and Wiltshire Partnership, which is our local mental health trust. Both universities in Bristol, so not Bath yet, but the University of the West of England and the University of Bristol, the local authority in Bristol, and all the local commissioning groups. So it's a very interesting mechanism for encouraging this sort of organisational collaboration. At the moment, quite focused on 2 key elements of the mission, which are health services and research. But this is the mission which a couple of years ago, when the partnership was established, we set ourselves a very ambitious mission, actually, very broad-ranging, really trying to have some effect at the level of the city region, have some measurable and notifiable impact on really the lives of the people who live in Bristol and the city region and their health, by focusing on health services, on research, innovation and education. And to date, the focus has really been on the first 2 of those. So looking at where evidence exists, for example, about the effectiveness of organising services in a particular way, or evidence exists about the effectiveness of particular treatments, and then getting that into changes to service as rapidly as possible. But those other broader areas, innovation and education, are ones which, if I'm being open and honest with you, which I am going to be this evening, we've actually found more difficult to progress. And then the other sort of general challenge, which Bristol Health Partners and this sort of mission fits into, is the broader challenge of, well, where does the health system fit into the city and the city region? What sort of relationships has the health system got in general terms to the place and organisations like the local enterprise partnerships? And what is the role of the members of the partnership with regard to that broader discussion, which isn't necessarily just about specific bits of research, specific bits of service change or delivery, but which is very much about health in the city, this much broader set of challenges. And pitching it in that way, it will come as no surprise to you, I think, to learn that this whole notion of system leadership, what that means, how we understand and promote it, and developing this sort of joint sense of purpose across a hugely complex network of organisations, which are often incentivised not to cooperate with each other, but in many ways to compete with each other, is very difficult, but also incredibly interesting and I hope rewarding. But what I want to sort of share with you this evening is my reflection on some of the successes that I think we've managed to date in Bristol with regard to this more general challenge, and some of the things which at the moment, on the basis of the couple of years that I spent working in the health system in Bristol, are proving more challenging. Now, as a former army officer, I've been sort of very used to structuring my thinking in terms of the tactical, the operational and the strategic. So I just want to sort of talk a little bit about what I think those mean in the context of something like this, and I'm going to offer you some reflections and some analysis using that outline. So for someone schooled at the UK Staff College, as I was, the strategic level is all about the sort of rationale for your endeavour. So it really is about what broadly are you trying to achieve, what do you want to be different, and what therefore effects do you want to have on the world or your own organisation. So very broad brush things about the rationale and the purpose of organisations or of systems. And then sort of stepping right down, the tactical level is all about what are the challenges you're facing on a day-to-day basis. What are the operations which you're conducting right now on the ground, and how can you coordinate those most effectively and deal with the sort of complexities which they sort of throw up on a day-to-day basis. And then in the middle of that is this thing which we refer to in the military as the operational layer. And that's really about slightly more esoteric issues about the way in which your overall approach is organised and the sort of operating model that you employ to address some of these broader challenges. So let me give you an example. The strategic level of the UK and Afghanistan, this is a personal view, these aren't the views of the government, but the strategic rationale, I think, if behind closed doors might have been articulated as something like staying close to the Americans, retaining a certain degree of influence with them and the international community more broadly, and in the longer term, preventing a country like Afghanistan becoming essentially a governance black hole where terrorist organisations develop, and thinking in the longer term about things like the supplies of energy. Again, not something which maybe you would have stated publicly, but the strategic rationale for the UK Afghanistan is about something like that. The tactical challenge in Afghanistan is day-to-day, the operations that are being conducted. What are we going to do over the next week? Who are we going to work with? How do we coordinate that? The operational level in Afghanistan is about the operating model. And that in Afghanistan is fundamentally about building indigenous capability. So the UK's operating model alongside the Americans was to promote and develop capability within the Afghans, the police, within the army, within the governance structures more generally. So those three different levels are ones which I've sort of continued to try and apply to the challenge of health in the city, and I want to use those to talk to you about some of the successes and some of the challenges. So the first slide is all, if you like, about the tactical level, and I think actually at the tactical level, as I've described it, there's a lot of very good stories to tell, because I would say that on the whole, the day-to-day experience of people in our hospitals, in somewhere like Bristol, the day-to-day experience of care and the quality of care is very good. We also have, I think, certainly over the last decade, and Chris will be much more knowledgeable about this than me and may bear some of the scars, we've actually done an enormous amount of changing, for example, the locations for the delivery of services. The specialist paediatrics have all now been centralised in one location, which is a sort of tactical challenge. I think we really shouldn't underestimate the complexity of making that work. But I think for me, ultimately, that's a tactical challenge. And then and associated with that, there's been an awful lot of investment in the estate in Bristol, and the sort of flagship project in that regard is the new hospital at Southmead. A genuinely world-class facility. It's been open now for a month and a bit, and that's as a tactical challenge and as an implementation challenge. I think it's on the whole been handled very well. I think there's also a good solid record of taking cost out of the provision of service. So over the last 4 to 5 years in a health economy like Bristol, the hospital providers have routinely managed to find a 4% reduction in the cost of the provision of service without, I think, a major reduction or any significant reduction actually in the quality of that service. And again, as a piece of sort of tactical success, I think that's really very significant. And on a day-to-day basis, people really are doing a great job in, I think, what on the whole are becoming increasingly difficult circumstances, both in financial terms, but also in terms of the uncertainty and the sort of day-to-day effect of the way in which the NHS is being reorganised on a sort of fairly routine basis. So from a tactical perspective, as I've described it, I think there's an awful lot of good stories to tell and an awful lot of good work going on. Taking it up to the operational level, I think it becomes more challenging. And so, for example, I think we struggle to deal with challenges which don't sit neatly across the structures that we've got. So, for example, the challenge of urgent care and how that's provided in the health economy. By urgent care, I mean the A&E departments. So right across Gloucester, North Somerset, Bristol, Bath, that complex network which is urgent care and which is also intimately connected with the way in which we treat older people, that is a complex operational challenge which we are finding it difficult at the moment to deal with properly, and it's because it doesn't sit neatly on our organisational structures. And kind of related to that point, I think that we obviously understand the demographics that are coming our way. We understand the increasing proportion of the population that will be above a certain age and is therefore likely to have certain types of conditions. But my sense is that we are focused, our response on that is largely focused on continuing to do largely what we're doing, but at a higher level of demand, rather than necessarily rethinking in a more fundamental way the sort of system that provides that support. And again, for me, that's about our operating model and a sort of operational rather than a tactical challenge. And then this is where I'd also sort of put our approach to technology, which I think in many ways still feels as though it's closed and proprietary, particularly when we're talking about access to data and access to, for example, patient information. so much of the discussion now is about the need to have a much more open and collaborative approach to the development of technology and access to data. And certainly from where I sit and the organisation that I'm part of, we really find that very, very difficult. And again, that's because we try and develop an organisational response to it, but what we really need to develop is a sort of system response to it, how we do things in Bristol and the health economy around here. And associated with that, I still think, if I'm being honest, we struggle to promote innovation within our organisations. There's an awful lot of innovation that does take place, and an awful lot of very, very innovative, intelligent, well-motivated people. But the way in which it still occurs still feels to me as though it's quite atomised. It pops up and it's supported, or it pops up and it fails because there are organisational barriers in place, or people just run out of enthusiasm. So the way in which we promote and support innovation, I think, is something from an operational level that we could improve. And then connected to all of this, not on the original points, but data within something like the health system is, I think, is a hugely underutilised resource. And there are a number of elements to that, either in terms of patient access to data or the way in which we more rigorously could use data to underpin our decision making in a much more disciplined way. And then from the strategic perspective, about rationale, about why it is that we've got the sort of type of health system that we've got, I think there's an even more sort of wicked problem. And I'd characterise it like this, that we have the desired direction of travel, if you like, for our health system, I think is largely articulated in terms of turning a system which is very much focused on the treatment of illness into one which also in some way promotes health in a more general way. So something which is more focused on prevention, which tries to deal with health challenges in inverted commas upstream. And it's remarkable from our perspective the degree to which there's consensus about that as the direction of travel within the health service. I don't know if they're being serious or facetious, but the only person who's demurred from that was a doctor who said, you know, why do I want people to become less ill? I'm going to be put out of business. But everybody else says, of course, this is what we should be doing. But when you step back from it and look at our record of making major changes to the way we allocate resources to change the system in that way I don't think is good. And I've tried to think about, well, why is it that is so problematic? What is it that we might need to address if we want to really start to change the way in which the system is organised and designed around a slightly different rationale, which is more about the promotion of health and prevention of illness as much as the treatment of illness. So these are a number of challenges which, again, I'm sure you will have heard articulated before, but for me, I think are central to this. The first one is we've yet to really engage the public in a discussion about the fundamental purpose of the health system and why it might need to change. And again, I've only got a couple of years of experience of sat in church halls or scrutiny committees, but that discussion feels very difficult to break open. And taking the discussion away from we're going to close an A&E department and people fighting to protect it to we have a challenge facing us all. We all live in this city. We know that we can't spend unlimited resources on the health of our population, so where should we invest it? How could we identify and be honest about the difficult choices that we've got? And associated with that, I think as well, is that although bodies like the Health and Wellbeing Boards and the commissioning groups have statutory authority to, for example, set out strategic priorities for the health system in our city, then I still sense that we still really haven't nailed the question of where is the central forum where we're all going to sit round the same table and agree what this new type of system needs to look like and commit to the changes that we need to drive through to change it in that way. And then as well, I think there's potentially sometimes a gap between the language that we use about system leadership and the way as organisational leaders we still behave, either in terms of the amount of our time we commit to the system stuff rather than the organisational stuff, and the amount of our resources, our people's time and brain power and also our money that we apply to big system problems rather than the operational challenges we've got in our own organisations. And then I think almost more sort of fundamentally, and this really is a wicked problem, is that I also have a concern that somehow we lack a articulated and explicit, if you like, theory of value. And I'm using this terminology because my first degree is in economics, so I think sometimes I think about allocative mechanisms, things like this. But what is the theory of value that underpins the way in which you allocate our resources? And at the moment the answer is I don't know. I think there are a whole load of embedded theories of value in the minds of people who allocate resources. So somewhere out there, for example, is an embedded theory of value that says there is more value in investing in the provision of cardiac surgery than there is, for example, in investing more in the prevention of cardiac disease. You won't never be articulated in that way, but somehow there are these implicit sort of embedded theories that determine the way in which we allocate our resource. And I think unless we try and break that open, then I think we'll find it very difficult to answer what for me is, kind of the exam question, which is, well, in a place like Bristol, where we spend about £1.3 billion a year in the health system. We know that we spend that because that's what the organisations who are in the system spend. But do we really know if we spend that in the best way, in the way that really promotes health in the city and which does all the things which we say we think are important? Well, at the moment, I think my honest answer is we don't know. And I think unless we talk in more explicit terms about what value means in our health system and where therefore we should allocate our resources, we will find that tough. So, in summary, there are successes, but as I've described them, they're, for me, tactical ones. The operational challenges and the strategic challenge about rationale and what sort of system we want to develop, I think is something which we are addressing it, but I just think that it's our ability to really sort of make progress at that sort of level, for me, is proving quite difficult. Technology, data and access, unsurprisingly, I think are still areas of big, underutilised and undiscovered opportunity. The way in which people, citizens in a city like Bristol are involved in a meaningful discussion about the future of the health system and the difficult choices that are embedded within that, I think is still very limited. I've got a concern that at this level, which is about rationale, then we've got sort of unhelpful conceptual frameworks which are kind of trapping us in a model which basically says keep doing what we're doing but just more and more cheaply, and that can't be the right answer. And of course, system leadership and how you really develop this joint sense of purpose across something like the health economy in a city outside London, like the place that I live, is, I think you'll be surprised to hear, very difficult. But these are the things which we must, find a way to crack. And I'm trying to sort of, do my and our bit through the partnership. I'm very interested in what's going on to look at these issues across other cities. So if you have any experience in that, then I'd love to hear about it. I know that Sheffield, for example, have made great progress in terms of potential pooling of health and social care budgets. They're probably further down the road than we are. I'm really keen to learn how in Bristol we can learn from what others are doing, because none of this I think will be unique to us, and neither will any of it be new. The slide which Chris showed earlier, where there's a big row of ones for the UK health system, and there's a big 10 at the bottom about healthy lives. That for me is absolute dynamite, because that basically says we have a system which is fantastic at delivering service. We have a health system which isn't really a health system. It's a fantastic illness response system. But the bit at the bottom about health and how we promote that, and the bit which we say we're trying to move our health system towards, we are still a long way from being, I think, where we need to be. So that is my presentation. I'd love to talk to folk afterwards. Thank you very much.